So welcome back, everyone, to part 2 of our cardiovascular clinical conversation with Dr. Mark Penn. Thank you all for joining us. My name is Rob Sherman, and I'm one of the product managers here at Sonora Quest Laboratories. We are once again honored to have our distinguished guest, Dr. Mark Penn, joining us. And as a reminder, Dr. Penn is the founder of Cleveland HeartLab. He is also the director of research at Summa Cardiovascular Institute and professor of medicine and integrative medical sciences at the Skirball Laboratory of Cardiovascular Cellular Therapeutics at Northeast Ohio Medical University. And he still somehow finds time to be a practicing cardiologist and sees patients regularly. So, Dr. Penn, thank you again for joining us today.
Well, thank you, Rob. Real pleasure to be here.
So, Dr. Penn, in our last conversation, we discussed the role that viral infections play in vascular inflammation and their impact on patients with pre-existing cardiovascular disease. Today, I'd like to talk about the role of vascular inflammation in cardiovascular risk assessment. So, Dr. Penn, as the founder of Cleveland HeartLab, I can't think of a better or more qualified person to speak on this subject. I was wondering if you would mind sharing with us the mission of Cleveland HeartLab, and then perhaps walk us through the biomarkers that help define cardiovascular risk.
You know, our goal at Cleveland HeartLab was to, using molecular pathways that define inflammatory proteins, come up with markers of vascular inflammation and oxidation to not only define whether the patient in front of you has risk, but where they sit on the acuity of risk, or how high risk are they. Our markers go from lifestyle measures of oxidation like F2 isoprostane in the urine to evidence of altered biology with oxidized LDL, where the LDL molecule is no longer recognized by the LDL receptor, and that's a risk of metabolic syndrome development. Then to presence of disease by high-sensitivity CRP, asymmetric dimethylarginine, or ADMA, as a marker of nitric oxide bioavailability, and albumin-creatinine ratio in the urine, which is a long-used marker, but with the cutoffs developed, define cardiovascular risk due to endothelial dysfunction. Then measure the activity of that plaque, not just the presence of plaque, being LPPLA2, looking at the necrotic core and activation or inflammation of that core that could lead to kind of chewing through the artery wall to a rupture, and myeloperoxidase, which is really looking at the lumen of the vessel, the inside of the vessel wall, looking for fissures, erosions, and plaque. It's important to note that the link between inflammation and atherosclerosis or heart disease is an old one, first put forth by Dr. Russell Ross when he was at the University of Washington in the late 70s. The response to injury hypothesis of atherosclerosis defines that there is an injury to the artery wall, which is likely cholesterol mediated, and the response to that injury is inflammation. We have really focused on the injury portion of the first leg of the hypothesis, if you will, by lowering cholesterol levels over the past 40 years. And now, to have the next profound benefit to our patients, we need to look at the second leg, or inflammation, because everybody's walking around in general on statins who have risk and somewhat lower LDL molecules or LDL levels. But the issue is who is still undertreated or has not had all the risk mitigated. And in the era of, literally epidemic proportions of diabetes and obesity, the sugar levels in our blood are driving inflammation. And at the same level of LDL, we still have higher risk because of the diabetes and the obesity. So it makes measuring inflammation really important. And what the studies have shown, the Women's Health Study, the Jupiter trial, and others, is if we as treating physicians choose to define our patients' lipid status or their inflammatory status, we are choosing to define half their risk. And it's really through looking at both sides of that coin, if you will, that we can fully define who's at risk, who needs more aggressive therapy, and quite frankly, and I think importantly, feedback to our patients who is doing well on their diet, exercise, and taking their meds, and who isn't.
Thank you for that, Dr. Penn. So we know that approximately 50% of heart attacks are occurring in patients with normal cholesterol. My question is, what role might measuring and then subsequently monitoring cardiovascular inflammation, play in helping healthcare professionals mitigate the risk of cardiovascular disease?
If we look at our panel of patients, everyone has again, there's a cardiologist who sees a lot of patients with a lot of disease. My patients have been treated with statins. Their LDLs have been lowered. I still don't know who in my population is still at risk of having a heart attack. Who's risk have I fully mitigated and whose risk haven't I? Using inflammatory markers gives us an option to further delve into who still has risk and who doesn't. If you have somebody who has an LDL of 76, post a heart attack, and their inflammatory markers are flat or normal, it's hard to imagine that further lowering their LDL is going to be beneficial. Conversely, if I have somebody who's got an LDL of 68, but yet their inflammatory markers are still elevated, I either need to lower their LDL levels more, or I need to figure out what's driving that vascular inflammation. But again, it might be a pre-diabetic state that's been unrecognized. It might be an abscess in their mouth. It might be they have rheumatoid arthritis and they're undertreated. Whatever it is, that patient still has unmitigated risk and it needs to be further treated. So I really think it's a valuable tool and a strategy for further risk mitigation. If somebody has an LDL of 200, they're at risk. I don't care what their inflammatory markers are.
Right.
But that's not the common patient anymore. 20 years ago, it was. And if you look at the clinical trials for LDL lowering, we're starting to have to treat 50 patients for 7 years to save a life. Well, if we could take that to, 20 patients in 2 years, that would be a real move forward. And I think using inflammatory markers makes a lot of sense to try to do that.
So, Dr. Penn, you and I have talked in the past about kind of the spectrum of risk. When we talk about maybe perhaps something like the lipid panel, we're assessing lifetime risk. If we look at maybe more advanced lipid testing like the NMR lipoprofile or IM mobility testing, we're maybe narrowing that risk down to decades-long risk. Can you speak to the fact that when we add inflammation, we can start to further narrow that window of risk down to maybe perhaps just the next couple of years? Help us understand how looking at inflammation helps us narrow that window of risk that we're looking at.
So the Jupiter trial was done in patients who all had high hsCRPs, but did not belong on statins and did not necessarily have coronary disease by definition. The benefit of putting somebody on statins because they have a high inflammatory marker, mortality benefit was seen within 19 months. So inflammatory markers generally identify patients who are near-term risk, and that treatment can have a significant benefit, again, in less than a handful of years.
Okay. So as one of the product managers here at Sonora Quest, I've had the good fortune of spending, lots of time with some of our great providers out here in the state of Arizona, healthcare providers. And I get two questions probably more frequently than any when talking about this testing. And the questions are, which patients should I test? And if I in fact identify a patient with cardiovascular inflammation, what do I do? How do I treat? Can you address those questions for us?
We assess are patients who have risk, either family history, hypertension, age, high LDLs, prediabetes, obesity, the standard risk factors. I don't think these are necessarily screening tools for people without risk. What to do about it is an individual issue, which is, from my point of view, one of the more interesting parts of this. Again, you see 100 patients in a day, and the question is, which handful of patients or two do I need to worry about? It's those who have high inflammatory markers from a cardiovascular risk point of view. And if they're elevated, if it's a middle-aged lady who has rheumatoid arthritis, who maybe is having some ache in her hands, or maybe not having any, but the reality is the inflammation or the vasculopathy associated with rheumatoid arthritis and the 5-fold increased risk of a heart attack in that woman has been undertreated. And you focus on that in her and make sure she's on a statin. If it's the 58-year-old who had bypassed 5 years ago and suddenly their inflammatory markers go up, it might be driving down lipids in that patient. But it may also be that they're not exercising and now their BMI is 28, 29, where maybe surgery it was 24 or 5. And the reality is their insulin levels are up. It may be that the person in COVID who, maybe had an LDL of 100 for a while, and now their inflammatory markers are up. And because of COVID, they haven't seen the dentist and they've got a tooth that's bothering them. And you get them to the dentist and get an abscess drained or get their teeth cleaned, and their inflammatory markers come down. It really is a patient-centric teaching or response. It is not, I got to put them on this drug. I need a myeloperoxidase inhibitor. It's really about taking care of the patient, which is why lots of us went into medicine. And that's exciting to me. And again, the key here is no one got there overnight, and no one's going to get better overnight, but we have to give them the care they need to get there. And some of it's diet, as I often say, it's just a challenge in America. If I give my patient the choice, which is better for you, 1,000-calorie steak and a glass of water, or a 500-calorie steak and a 250-calorie Coke, most Americans will say it's the steak and Coke because it's 250 calories less. And what they don't appreciate is pouring that sugar on top of the fat in the steak is much worse for them than eating a steak that never leads to insulin release. So it really is about educating our patients, teaching them a lot of things that they don't know and you might think they know, and helping them, get back on the wagon, if you will. It's not high science molecular targets. It's just good medical care.
Yeah. Another question I get all the time is, well, what do the cardiologists think about this testing? And you and I have had discussions offline. I tend to generally quote you. Now that we've got you with us today, how about hear it right from the horse's mouth? So what say you about what cardiologists think about this specific testing? As it relates to the primary care setting, not necessarily cardiology.
I think cardiologists recognize that lesions that cause the heart attacks are 20, 30, and 40% lesions. And that's what we're finding. And there was a very nice study out of Ireland earlier last year that showed low attenuation plaque, which is kind of soft fatty plaque. It's not the big calcified plaque, is the part that puts us at increased risk. And that's also the inflamed plaque. So we recognize that. I think cardiologists also recognize that when these markers are high, it doesn't mean they need to be capped. It doesn't mean they need to be stressed, because the reality is there may be no 70+% lesion. But cardiologists are really good at stopping heart attacks. We're not really good at preventing heart attacks. And so, as much as we turn to cardiology at times to be the group that tells us what we should be doing to prevent the disease, it's really in the hand of primary care, internal medicine, GPs, and quite frankly, the OBGYNs, who are really the primary caregiver for older women. It's their role to prevent the heart attacks with aspirin, statins, minimizing insulin levels and sugars and things like that. And really none of our markers have been designed nor been proven to require a cardiology referral, because there isn't chest pain. And again, these are often lesions that we don't really pay attention to when we cath somebody.
So, I think it's safe to assume that by now, most patients have come to understand to some degree that too much bad cholesterol can put them at increased risk for cardiovascular disease. And therefore, doctors are quite comfortable having these discussions with their patients. The same might not be true of doctors' comfortability having discussions with patients about cardiovascular inflammation. So my last question to you, Dr. Penn, would be, how would you advise a doctor or other healthcare professionals on how to have a conversation with their patients about cardiovascular inflammation and what impact it can have on their overall cardiovascular health?
The key point here is that if you're measuring inflammatory markers and you're finding them to be positive, the most common driver of those is metabolic dysfunction. So it's weight, it's lack of exercise, it's diabetes, it's sugar, and it can be lipids. And I think the best thing to do is twofold. One is to use the markers to demonstrate to the patients that they're actually being successful in decreasing their risk. That's important. And it helps them buy in and it helps them continue. It also allows them to understand they might fall off the wagon, but they can get back on and improve these things. The second thing is to help them understand how their metabolic state is increasing their risk. Because clearly LDL is important, and I would never be quoted to say it's not, but they're missing the point that lifestyle and what they eat beyond just fat is bad for them and can significantly increase their risk. And the other thing that patients, subjects, and frankly, the US population doesn't understand is low fat is often code for high sugar. Sugar is a good preservative. It's heavy. If you're, getting paid by the pound, it's good. But the glycemic index, how easy that sugar dissolves in the bloodstream, is really important. You can eat oatmeal, true oatmeal, and cook it, and it takes a while, and it's good, and it lowers your cholesterol, and it's good for you. You take instant oatmeal, where those oats have been broken down so that they cook faster. All that carbohydrate that you wouldn't have taken up in whole oats is now going straight into your bloodstream. And so using inflammatory markers to identify for those patients, who's really at lifestyle metabolic risk, and then helping them understand they didn't get there overnight, we'll get you back to somewhere better over time, and help them understand how all these food choices and lifestyle choices affect them. I can't think of any better way to engage with a patient and help them understand how they can help themselves. Because a lot of atheroma and atherosclerosis we deal with is a man-made disease. We were never meant to have this easy access to food, and we got to learn how to live with it.
I said last question, but you've teed me up talking about food. There's some eating habits out there that have grown very popular, to the point you were making. Sugar, carbohydrates, bad, lead to inflammation, the root cause of, heart disease, diabetes, so on and so forth. My question would be, for patients with existing cardiovascular disease, there's this new push towards these high-fat diets, Atkins, ketogenic diets, where you get in a state of ketosis and you're burning your fat for energy as opposed to your reserved carbohydrates. What impact does a high-fat, low-carbohydrate diet have on patients with existing vascular inflammation? Does it help, hurt, or what does the data tell us?
You look at Nutrisystems, you look at Weight Watchers, you look at Forks Over Knives, you look at South Beach Diet, you look at all of them. They all have one thing in common. They all decrease insulin release. And fundamentally, that's the key. Insulin's a growth factor. It adds to atheroma. It can lead to vascular inflammation. They all decrease inflammation. The challenge, I think, in looking at diets is what diet ultimately allows you to eat well. I mean, Atkins works. I've done it. A lot of folks have done it. But boy, you don't know how to eat when you're done. So unless you're committed to it forever, which, maybe you are, maybe you aren't. But unless you're committed, when you stop these things, you really don't know how to eat, and the weight goes back on and the issues recur. So it's really about how are you going to learn to eat for the rest of your life. And, the vegan diets are important. They work. Vegetables, cooked vegetables in particular, don't have zero glycemic index. So it doesn't mean you're going to be skinny, and you can still release insulin. But at least it's a way to eat that is relatively healthy compared to most of our diets. But it's really about, and I say to patients all the time, it's all about moderation. I mean, the size of the dinner plate has, gone up significantly in the last 20 years. And it's really about moderating things and getting out and using your calories and exercise. And through that balance, I think a lot of us could live a better life, have less metabolic issues, and then drive less disease. But to help motivate patients and for our physician colleagues to be able to find those patients, inflammatory markers are really a very important way to identify patients who need that and need our guidance and our education.
Well, thanks, Dr. Penn. I think that's a great place to stop. And I just want to thank everybody for joining us today. And obviously, my special thanks to our guest, Dr. Mark Penn. Dr. Penn, thank you so much again. Really appreciate you
Thank
being
you.
with us.
It's a pleasure.
Great. So we hope that you found today's discussion helpful. And once again, if you have any questions, please direct them to me. I can be reached through email at rob.sherman@sonoraquest.com. So again, thank you and be healthy.